Side effects: constipation, respiratory depression, sedation, and we'll talk about the ones that are actually mainly we see with chronic use. Hormonal imbalance, like suppression of hypothalamic pituitary axis. People might have lower level of testosterone, for instance, in males. Osteoporosis, tolerance, urinary retention, cognitive impairment, dependence and addiction, and opioid-induced hyperalgesia, which is very interesting phenomenon. So if you want to actually provide a trial of opioid, based on the dose required to achieve the analgesia, you can use half of this dose as a long-acting form and then titrate it upwards. If the patient actually requires greater than the 100 milligrams of oral morphine equivalent, you should always consult a pain specialist for sure. And this equates to the following: if you're using slow-release oxycodone with 70 milligrams daily, or 25 mics an hour of fentanyl patch every 3 days, or using 20 milligrams of hydromorphone, you have to refer to the chronic pain specialist. Opioids in the chronic non-cancer pain should be only utilized for 3 to 6 months. Contracts are usually recommended in which you bind yourself with the patient to follow certain instructions. And then after the first 3 months, you have to try and sort of wean and cease the use of opioid. During the therapeutic phase, patients should be achieving a higher level of function, which is usually achieved without opioid if we can, and consider rehab, physician review, as well as osteohistory, disability index. Examples of the opioids, as I said: morphine 10 milligrams, the buprenorphine, or methadone. We use it usually in condition where regular opioids are not working, or severe neuropathic pain. The problem with it, it actually has a long half-life, can go up to 150 hours. It's very variable in patients. And it's usually prescribed by chronic pain specialists or palliative care givers. Usually you have to start with a very low dose. Example is 10 milligrams OD or PID, and then you titrate it up. Sometimes we start 2.5 or 5 even milligrams. There is always requirement to start methadone. You have to always have an ECG pre-treatment. Be aware of the prolongation of QT with the methadone and the risk of torsades de pointes. Medication which combines both oxycodone and naloxone. It's not available in the kingdom yet. The naloxone usually is not absorbed systematically, but it does give you the antagonistic action locally, which reduces the chances of constipation from the gut. It's usually, as I said, recommended in opioid-induced constipation, which is one of the worst long-term side effects that we usually will not wear off easily. The dosing is 2:1 oxycodone to naloxone. The advantage is less likely for abuse than oxycodone or slow-release oxycodone. Pharmacokinetically similar to oxycodone or slow-release oxycodone.